Hi, good afternoon to all of you, to Caro and Octavio. Can you listen to me? All right, so let's get going. Today's subject, we will be talking about trauma, which is fairly easy. It is pretty much about logic. This is based on the ATLS protocols, and it's very important for you to have some basic ideas about trauma management. So we will be talking about the famous golden hour, in which we have to act accordingly in order to save a patient. We will be addressing the ABCDE about airway management and shock management, and about ample story history, the main data that we have to ask in order to have the whole picture complete. Now, the distribution of mortality about trauma, as you can see in this by the World Health Organization, it is unintentional injuries, and as you can see here, about 22.8% correspond to road traffic injuries, which is almost a quarter of it, and other unintentional injuries. So we have to act fast, and we have to recognize trauma and their main lesions during the first hour. This is a classic graphic about the three ways of distribution of death. That means that half of the patients that were involved in some kind of trauma are going to die right there and then within the first minutes. Now, those who survive, we have to act very fast, which is the other 30%, and the main lesions correspond to the airways or blood loss. And after that, we have to be very careful, because there's another 20% that may be in a serious condition during the several days after the trauma. So you see here, in the first hour or in the first minutes, if you had a trauma to the, let's say, to the heart, or you have a rupture of the great vessels, such as the aorta, or severe brain trauma, then you're going to die within the first minutes. The patients that we're going to be addressing during an ambulance transport, or during on our watch on surgical or trauma bay, are over here these that arrive to the hospital, that actually arrive to the hospital with serious lesions, but they can be saved. And in such instances, we have pelvic fractures, hemopneumothorax, or brain trauma, such as epidural or subdural hematoma, and other abdominal injuries. Now, afterwards, we have to be very careful about the main cause of trauma and what other lesions, and in time, the complications of trauma are either sepsis or multiple organ failure. And we have to, there's a system we have to approach in an orderly fashion way, and understand that we can, or about 30% of deaths can be prevented. So During the first hour, we have to approach trauma very fast, very accurately, on a very thorough way. And we have to address every effort to increase the chances of survival and to restore the individual to normal functions. So this is in the pre-hospital care. You're not going to see this. This is going to happen during the ambulance with the paramedics and stuff. What you're going to see is when you're in an emergency department, you're going to have your patients, and you need to start aggressive resuscitation and prompt interventions. So the platinum 10 minutes is where you put yourself tagged to your patient. Is he with severe injuries that may be causing a probability over 50% that he may die? Is it urgent or non-urgent? Fortunately, about 80% of the cases are non-urgent. I mean, they have to be addressed quickly, but they are non-urgent. About 10 to 15% are urgent, and as severe, we have less than 5% of the cases, which is okay, because you know this, and those cases will be arriving not very commonly. So what do you do first? After the patient has been transported, you're going to perform a primary survey. And primary survey refers to as your first examination that you do. You have to do your ABCs, and then you do what's called a secondary survey, which is more a thorough examination, and you order some complementary laboratory tests or imaging tests such as X-rays or CT scanning or angiography, and then you need to go back forward and re-evaluate, and then you establish a definitive care. So in the pre-hospital phase, this is before arriving to the trauma bay itself. You're not going to go through this. This is the ambulance or the paramedics or the militaries or the policemen. And what they have to do is just to provide some ventilation and spine stabilization. That's up to this point is everything that needs to be done. Now, when the patient arrives to the hospital space, we don't have this in Mexico City, but sometimes in the pre-hospital phase, they used the pneumatic anti-shock garments in order to prevent blood loss, especially when there's a pelvic fracture. And you can see these are the pneumatic anti-shock garments. We don't have these in here, so this is for you to acknowledge that they may exist. If you have multiple casualties, let's say there's been an earthquake or massive earthquake, and you need to establish right away who gets to be attended first. And in order to do that, there's a triage system that identifies victims in order to who has the best chance to survive. That means you put a color tag on the patient, so the other people that arrive to the trauma scene, they may identify it right away who needs the attention. For instance, we have these colors: black, red, yellow, and green. Black goes for the victims that are already dead. So you put a tag on it so that everybody can notice that those victims are already dead, so they don't waste any efforts going there. Those in green, it says they have minor lesions such as lacerations or minor bruises or minor bleeding such as a finger or a little bit in the arm. Yellow goes for a bit, they're not urgent, but they have to receive some sort of attention. And red goes for the ones that are in a pretty serious condition that needs to be attended right away. Therefore, you address all your efforts in order to get the people that needs the attention immediately to take into the trauma bay right away. So this is simple, and this is a universal language. In case you have to do a triage, you do this, and this is a universal language in every hospital through the entire world. After that, well, the patient arrives and you need to do your primary survey, which has to be the A, B, C, D, E, and E, F. A accounts for airway, and C, spine precautions. That means you're going to get your patient immobilized by a neck spine. Then you're going to check on letter B, which accounts for breathing and ventilation. You have to check out if the thorax is moving symmetrically, and you have to listen to the breath sounds in both sides of the thorax. Then you check for circulation and hemorrhage control. That means you check if your patient is hemodynamically stable. That means that he's not hypertensive, not tachycardic, and you don't see any visible locations of bleeding. And then after you resolve ABC, then you check for D, which accounts for disability or neurological status, and E, exposure. Exposure, that means you're going to cut off his clothes and you're going to perform a thorough examination. And F goes for frequent assessment. So all of this isn't like, all right, then you first do A, then you do B, then you do C. As a matter of fact, on a trauma bay, one person is in charge of letter A, one person is in charge of letter B, and one person is in charge of letter C. That means 3 or 4 people arrive to the patient and start acting immediately, simultaneously, which is very important. So the airway is very important. You have to pull the jaw and to correct the airway, and always you have to assume that the patient has been involved in a cervical spine trauma. So you have to immobilize your patient until you prove that your patient doesn't have any cervical lesions. All right. If there's a high-speed impact and your patient arrived unconscious, again, you have to assume that that patient had been involved in a cervical lesion trauma. You assume this every time, and you put a spine collar. Once you check that the patient doesn't have any cervical lesion, then you remove the collar. All right. So what do you do first when you see this trauma setting? What every patient needs to be taken to the trauma bay. They put a cervical immobilization, because we always assume that the patient has some cervical spine lesion, and this way we can prevent any further neurological deficit or paralysis, and we protect it. Once we find out that the patient doesn't have any cervical spine lesion, then we can remove the collar. Is this clear so far?
Yes. Yes, all clear, thank you.
All right, so after that, then you check your airway. As a general rule, if your patient arrives talking, then you have no problem with your airway. And therefore, you don't have any problem, again, with your breathing, because if the patient arrives talking normally or yelling, then you don't have any problem in the airways. Then you check his oxygenation levels, and then you move through letter C, all right, to check if there's any visible signs of bleeding, or if your patient is hemodynamically unstable. That means he's hypertensive and tachycardic. You have to suspect that your patient is bleeding internally. Now, this is, you have to look, you have to listen, and you have to feel. You have to look at your patient. Is he agitated? Is he falling asleep and he cannot stay awake until either you're talking to him? So both status correspond to or suggest some kind of hypoxia and increase of carbon dioxide. It's very important for you to look at the breathing pattern. That means your thorax, is it moving properly? Is it moving symmetrically? And then you have to listen to the breath sounds and to the heart sounds. So this is very, very, very easy, but first you have to look at your patient. If your patient arrives agitated, anxious, screaming, make sure he has enough oxygen. Listen, then you have to listen to everything. Is he snoring? Is he gurgling when he's breathing? And you take your stethoscope and you listen to both sides of the thorax. And if you don't listen to one side, then you have to suggest that your patient has either a pneumothorax or a hemothorax. Be very aware of what you listen. Now you have to feel. What do you have to feel? You have to feel the trachea. The trachea has to be a little bit mobile, and it has to be on the center, in the midline. You have to look out for foreign objects, and you have to touch the thorax of the patient. Very gentle, but very firm. If you feel anything that crunches, then you have a fracture right there and there. So look, listen, and feel. Now, if you suddenly see your patient is not oxygenating properly, and you don't hear any breath sounds, make sure his tongue is not obstructing the airway. Make sure that your patient doesn't have any foreign bodies on the pharynx or the larynx. Make sure you make aspiration of the gastric contents. And there's a contraindication for oral tracheal intubation if your patient has any fractures on the mandible or on the facial structures. And if your patient arrives, I didn't put that in here, but if your patient arrives in a drunken state with a Glasgow Coma scale less than 8 or equal to 8, you have to make an oral tracheal intubation. You have to secure the airway. And
what was the contraindication for the intubation?
That you have facial fractures, that you have the mandible fractured, or that you have well, those are the main contraindications for oral tracheal intubation, that you have facial or mandibular fractures.
Okay, thank you.
Of course, if you suspect that your trachea has been broken, that means you have subcutaneous emphysema. If you suspect that, then it is obviously contraindicated to perform an oral tracheal intubation. So we're still on letter A, as you can see. We have to make sure that our patient has a clear airway, and we do this by making a jaw thrust, lifting it, the chin, and that corrects the position of the airway. How do we make sure that the patient is breathing spontaneously? Well, we have to see that the chest of the patient rises up in every inspiration. Always look at the chest. If your patient has some clothes on it or something that is obstructing your looking at the patient, you have to cut it off. Always look at your patient. How do you make sure that your patient is breathing spontaneously? You have to see the elevation of the chest in every respiration. After you see that, then you corroborate that by listening to both sides of the thorax. If your patient is not breathing, or you don't hear anything, and you don't see the elevation of the chest, then you have to intubate. Always secure your airway. Now, if you don't know how to intubate or you don't feel confident enough, you grab your mask, your oxygen mask, and you put it there. You make your jaw thrust. You lift your chin, and then you ventilate manually. This is very important for you to know. If your patient's not breathing and you don't know how to intubate or you don't feel confident enough, then you may use an ambu bag, which is a bag with a reservoir, and you start ventilating your patient. Is this clear?
Yes, very clear.
All right. So after that, see here, this is a jaw thrust, this is a chin lift, a jaw thrust, and that corrects immediately the airway. You can put this back over here with a back reservoir, or you can use the other bag that you push the air into the patient. Both of them are fine. Now there are airway devices that you can use. Either this is a Guedel or pharyngeal cannula that prevents the tongue to obstruct the airway. So you just put it there in the mouth of the patient and you rotate it 180 degrees. So it prevents the tongue that obstructs the airway. This is very helpful. If you have it, always use it. There are nasopharyngeal cannulas to secure the airway. This is not very common that they have this in hospitals. This is very common. When they have it in the hospital, you just stuck it right you insert it in the mouth, and it goes directly into the laryngeal space, and then you start bagging your patient, oxygenating him. Now, well, these are the basic maneuvers for you to handle the airway, but if your patient is breathing spontaneously, then you provide him oxygen by nasal cannula. If your patient is not breathing spontaneously, then you have to take over his airway, and you have to start breathing for him. If you don't know how to intubate or you don't feel confident enough, then you just put a mask over the patient's mouth and nose and start ventilating him. Now, if you have or you suspect that your patient has some injuries to the larynx or to the trachea, well, you have to take this patient immediately to the operation room to take care of this airway right away. How do you make a definitive airway, well, if you have fractures on the mandible or on the face, well, you need to take this patient to the OR to perform a surgical tracheostomy. After that, well, there's how do you secure your airway? I mean, with orotracheal intubation. If your patient's not breathing, if your patient has a Glasgow Coma scale below 9, if your patient is in cardiac arrest or has high risk of gastric aspiration or severe hypoxemia, well, whatever, if your patient is hemodynamically unstable and is not breathing, you have to make sure that your patient breathes again. This is a classification for you to assess how difficult it's going to be to intubate your patient. That's lemon that goes for look externally, evaluate, make the Mallampati scale, that means how open is the mouth of the patient to insert a tube, if he has any kind of obstruction, and the length of the neck. You don't have to learn this, but you have to know that it exists, the classification to assess the difficulty to make an orotracheal intubation. As you can see here, the Mallampati classification, when you open your mouth and you can see everything, then there's an easy insertion of the tube. But when you don't see anything, then you're talking about a difficult patient, and then that you expect it to be difficult. But again, this goes for anesthesiologists. You don't need to learn this. I'm not going to ask this on your tests. Now, there's how do you intubate? You make sure you have your 7 Ps, which is preparation. That means preparation of your equipment. You have to make sure your laryngoscope is functioning, that it has enough light, that you have your cannulas of the right sizes. Then you oxygenate your patient, and there's pre-oxygenation about 3 minutes. You have to achieve about 98 to 99% of oxygen saturation. You give a pre-medication. That means if your patient is awake, you have to sedate your patient, and you have to infuse some paralyzing agents. If necessary, you have to apply some cricoid pressure, or otherwise called the Selig maneuver. That means if your trachea is quite anterior, you may want to push it down just a little bit so that you can have a better vision of it. Then the placement of the tube, the position of the tube, and afterwards you take care of that patient that is being intubated. If you want, you can practice this at the simulation area. Whatever you have the time, we have the equipment available so that you can practice this maneuver. Of course, you have to check your laryngoscope and make sure it works. I'm going to show you this. So you see how a patient gets intubated. I'm sorry, okay. Here's the video that you can see. Look at he's lifting the epiglottis, he's lifting it. That's the Selig maneuver. There's the larynx. There's the epiglottis. There's the tube. That's the Selig maneuver. When you push it, he's doing the Selig maneuver. There's the larynx. You have to look directly, and these are the post-intubation take care of the tube. You have to secure your tube in order for it to stay in place. This is a nice video. It shows very well. You can't see the video properly?
No, it looks like paused and it doesn't look well.
The transmission is too slow, so it like yeah.
All right, try to watch it with all right, the presentation is already uploaded to the Blackboard. Try to download the presentation and watch it on your laptops later on. You can it is very clear when the doctor is intubating the patient. You can see the structure is very clear. The epiglottis, when he's lifting the epiglottis, and you can see the Selig maneuver when he pushes down the cricoid cartilage, and then you see completely the larynx. So try to watch it later on. And well, you have to do your suction, you have to put the oxygen, you have to make sure after you intubate your patient that your cannula is placed in order. That means right before the trachea divides the two main bronchi, because sometimes you can insert the tube so much that you introduce it in just one bronchi, but you have to listen with your stethoscope after you intubate your patient that both lungs are well ventilated. I have a question here. It says, I have seen that there are a lot of different, yes, laryngoscope sheets. All right, you will know according to your first assessment. For instance, if you have a patient that is fat and has a short fat neck, and well, you assume that his airway is a difficult airway, so you want to pick a long sheet of the laryngoscope so that you can insert it a lot easier. But if you have, in the other extreme, you have a patient that has a very long neck and is very skinny, and when he opens his mouth, you can even see the larynx without making any effort, then you need a short blade of the laryngoscope. It depends on the assessment, on the first assessment of the patient. What are the complications? Well, of course, that you lacerate the larynx or the epiglottis and you cause some edema. You may cause some lesions to the vocal cords if you intubate not delicately enough. You can lacerate the trachea, and afterwards it may cause edema and stenosis. You can cause some sort of complication after the intubation. So there's a procedure that you want to practice it, and you have to do it quite gently. So you always suspect a cervical spine injury. You oxygenate your patient. If your patient's not breathing, you have to intubate your patient. If you're not able to intubate, then you ask for help, or you, well, that patient needs to be on a surgical forms. Then if your patient is breathing, then you help him with a bit of oxygen. If you're not able to intubate your patient, well, then request help or give some sedatives. If you're still not able to intubate, you don't force this, please ask for help. You're not alone. Otherwise, you're still ventilating until help arrives. What's the surgical airway? Then you do a needle cricothyroidotomy, which is the insertion of a cannula on the thyroid membrane into the airway. It is a quick procedure between half an hour or 45 minutes, and you perform this when you are not ventilating the patient well enough and you have facial fractures. Then you perform this. You need to peel the cartilage, the cricoid cartilage, and then you make an incision and dissect the muscles, the pre-thyroid muscles, and then until you find the trachea, and then you open the trachea and you insert your tube. It is a simple procedure, but it's not common that you will perform it. Most of the times you can intubate your patient. I have a video over here. I hope you can see this. This is a cricothyroidotomy. You just need a blade, some scissors, and your cannula. That's the cannula that you're going to insert. Then you insert the tube that's going to be having your patient breathing. There he is feeling the cartilage. And then he's making an incision. It is a very simple procedure. You can do it. So you open up, you feel the trachea. See? You're separating the pre-thyroid muscles. He needs to find the trachea, and once he's done that, he opened it up and he introduced the cannula. Afterwards, the airway is secured. There you go. That's it. This is a longer tube You can use either as long as you secure the airway. So, if none of that works, or your patient it has been intubated for 14 days, he needs a definitive airway. That's when you perform a tracheostomy, or he has been bleeding or had some sort of trauma to the larynx or to the trachea, or fractures in the thyroid cartilage. So you need to perform a tracheostomy. This is almost as the one you saw before, but it is performed in the operation room, and it's performed by a surgeon. So how do you assess breathing? You have to listen to both sides of the thorax, and if there's some abnormal patterns of breathing, you have to make sure that there are no lesions into the thorax. If there are, you have to address them promptly. What are the life-threatening thoracic injuries? Well, this is airway obstruction, tension pneumothorax, or open pneumothorax. Massive hemothorax, that corresponds to have at least 2 liters of blood in one or both hemithorax. The definition of flail chest, can you recall that? That's having 2 sides of fractures in two or more contiguous ribs in one side of the chest.
Yes, we remember. Well, I remember.
Yes. Now, as for the tension pneumothorax, this is a very serious condition. You're going to see your patient that is not breathing. It is losing saturation of oxygen, and you have to act very fast by making a puncture. You have to decompress immediately on the second intercostal space on the mid-clavicular line. And by this maneuver, you are converting a tension pneumothorax into an open pneumothorax. As you can see here, this is a tension pneumothorax, and you have to make a quick puncture in the second intercostal space, mid-clavicular line. Any questions over here? Because this shows in the test. All right. Okay, don't ignore this slide. How are you going to find your patient? Well, of course, there's going to be some chest pain, hypotension, tachycardia, unable to breathe, and you're not going to hear any breath sounds on the affected thorax, and the percussion is going to be a resonant. This is a tension pneumothorax X-ray. And as I can see, as I told some of my students earlier, you don't wait until you have an X-ray of a tension pneumothorax. When you look at an X-ray, you're looking at an X-ray of a dead man. You have to identify a tension pneumothorax only clinically and act very fast, otherwise your patient's going to die within minutes. So that's it. I told you just that. And afterwards, what you do is you insert a chest tube properly. And after that, this is a video. After you decompress that tension pneumothorax, as I told you earlier, you convert this from a tension pneumothorax to an open pneumothorax. And once you have an open pneumothorax, you insert a chest tube so that you can correct definitely the problem. You infiltrate local anesthetic. You perform this in the 5th intercostal space, anterior or middle axillary line, and then you open up with your surgical blade, and then you puncture the parietal pleura, and then you insert the chest tube, directing it upward and posteriorly.
And that procedure is when you have the open pneumothorax?
Yes, that's correct. Or either open pneumothorax or a hemothorax. In both cases, you perform the insertion of a chest tube. So he's dissecting the muscles of the chest wall over there. He's introducing his finger to feel the ribs and the intercostal space, and the direction he will be guiding his chest tube. He's measuring the chest tube. There, he's going to open the parietal pleura by puncturing the thoracic wall, and then he's inserting the chest tube until the mark of the patient's size. He's not cutting that. That is going to be connected to a water seal, and then you suture your patient so that it doesn't have any air leaks And by doing this, you are restoring back the negative intrapleural pressure so that the patient can breathe. And that's it. The massive hemothorax is that you have blood, at least 1,500 milliliters of blood in chest cavity. And of course, your patient is not going to be able to breathe. You're not going to hear any breath sounds. And the treatment is the same thing. And the pleural chest, well, your patient is not going to breathe. And the definition of pleural chest is having two sides of fractures on one rib, on two or more consecutive ribs. And you're going to have asymmetrical in the thoracic movements, and when you touch the chest wall, you're going to feel some crepitus, and that means that you're feeling the broken ribs. The treatment is the same. You have to ventilate your patient. You have to insert the chest tube in order to correct the pneumothorax and the hemothorax. You have to administer oxygen, and you have to provide a good analgesia, because broken ribs, they can hurt a lot. Of course, the cardiac tamponade is going to be lethal if you don't identify it fast. And you can identify it by looking at if the patient has the Beck triad, which is distended neck veins, a drop in blood pressure, and you don't hear any heart sounds because of the liquid. And, well, finally we move to the letter C. If you see that your patient has lost lots of amounts of blood, he's going to be in a clinical state of shock, which is being hypertensive, tachycardic, and perhaps he's not going to be with a perfusion state, so he's going to have neurological deficit. And the treatment of shock, well, is to attend the main cause. That means if your patient is bleeding from somewhere, you have to stop that. If he is bleeding internally, then he needs to be taken to the operation room immediately. And of course, you have to administer at least 2 liters of crystalloid solutions. If he's losing a lot more blood than that, you have to administer again a blood transfusion, and whatever he needs, you have to address the main cause. What you're going to see that they will try to avoid on a trauma base, the famous triad of death, which is metabolic acidosis, hypothermia, and coagulopathy. That's why on the ambulance they cover the patients with some sheets, with some metallic sheets. Have you seen this? It is to avoid hypothermia. As a matter of fact, on the Red Cross, they have their crystalloid solutions are kept on warm water, so if a patient suddenly arrives in a shock state, they infuse him these crystalloid solutions, and they are already warm in order to reverse the hypothermia and to avoid death of the patient. And well, this is the classification of hypovolemic shock. Accordingly to the amount of blood loss is the classification. The greater the loss, the greater the class, and the worse the prognosis. So class 1 is accordingly to losing about 750 milliliters. That means less than 50% of the blood circulating volume. Class 2 ranges between 800 and 1500. Class 3 between 1500 and 2000. And class 4, it is greater than 2000. And as you can see, the pulse is very fast with a lot of tachycardia. His blood pressure is almost undetectable. His respiratory rate is with tachypnea. He's pale, he's cold, and well, he may not be awake at this time. So according to the blood laws, you're going to find the clinical signs of it. So what do you do first when? Well, then you address this by identifying where is your patient losing blood and address immediately. And you infuse 2 liters of crystalloid solutions and then transfusion. If you have a long bone fracture, such as the femur, your approximately blood loss is about 1500. If you have a pelvic fracture, this is very serious condition. You have between 2000 and 2500 milliliters of blood loss. So according to the lesions that you found or that you find, you may establish a bit of how much blood loss the patient has had. So that's it. You address the main cause, and you manage with crystalloid solutions and transfusions. And well, that's it. You may have some 3 kind of responders. If you infuse your solution, your 2-liter solutions, and the vital signs return to normal, then you have a patient that is a responder. If you have a patient that responded at first well enough, and then he is starting to decline his vital signs, then you say you have a transient responder. And if you have a patient that you infuse in crystalloid solutions and then transfusions, and he's not responding at all, then you have a patient that is non-responder, and you have to take him to the OR immediately.
I have a question.
Okay.
Yes. What does it mean in slide 73? There's something in red, and it's, I don't know what, it talks about a central line, I think. Is it? Yeah, that one.
Yes. Yes, I crossed that because where you infuse your crystalloids is through peripheral veins. All right, peripheral veins. It is contraindicated to perform a central line during your resuscitation because it consumes time. So if you see this is a malpractice action. You don't put any central venous catheter on the resuscitation trauma bay. You do that afterwards, but not in the resuscitation time.
Okay, thank you.
That's why you're welcome. That's why I crossed it. It is contraindicated. See, a central line over here, it is contraindicated. You do that through peripheral lines. And well, that's it. The only thing that you're going to use is crystalloids, either finger lactate. It depends on the pH, but most of them you use saline solution. Colloids are contraindicated. All right? Any questions?
So colloids are completely not indicated unless there's a very, very, very urgent situation, or you never, absolutely never give them?
No, I have to change these slides. They are forbidden in trauma resuscitation. Only crystalloids.
Okay.
So I told you this is an easy subject, right? It's not that hard. And it's kind of exciting.
Yes.
All right, well, thank you for being here. There are 2 more subjects, and I think that's it. I will upload another test, and you have 1 week to answer it, as usual. There will be, up to this point, no activities but to answer tests. All right? I thank you all for being here.
How many tests do we have left until the semester is over?
I'm sorry, say again?
How many tests do we have left until the semester is over?
Okay, there's one more other, I think 2 more, and then the final exam.
Okay, thank you.
You're welcome. Well, I guess I will see you next week. Next week will be at 5:30. Thank you for making this exception today.
Okay.
That's fine.
Okay, thank you.
Thank you. Bye.
Bye. Have a nice weekend.
Thank you. You too. Bye-bye.